Dear chairs, dear colleagues, I thought my planned subject on resource usage and safety would be a bit dry and not helpful for digestion right after lunch. So I decided that I would like to talk to you about implementation science and how to bridge the no-do gap instead. But first, a bit of background on our PMI project. Many surgeries take place globally as well as in Switzerland. Mortality rates are with 7.7% higher than previously anticipated. A quarter of those surgeries are done in cardiovascular high-risk patients, which are especially vulnerable. We were able to show in Basel that 13% of those high-risk surgery patients experience a perioperative myocardial infarction/injury, short PMI, defined as an absolute increase in cardiac troponin of over the 99th percentile above preoperative values. But far less than 10% of those patients show symptoms of myocardial ischemia, leading to missed diagnosis and treatment of this cardiac complication. This is particularly grave since mortality of patients with PMI is significantly higher, and the one-year mortality rates with patients with PMI is 17 to 49%, depending on the etiology. In Basel, we started with an active surveillance for PMI, where we identify high-risk patients before their surgery. We then measure troponin preoperatively as a baseline, and then postoperatively on day 1 and day 2 after the surgery. If we detect a PMI, the patient receives a cardiology workup. Our efforts in this field are even supported by the new ESC guidelines from 2022, which recommend a systematic troponin screening in this high-risk population with an evidence level of 1B. But this is sadly not enough. It is estimated that it takes a mean of 15 years to get evidence-based practices implemented, and only as little as 14% of evidence-based practices are ever implemented. So you could provocatively so say that 86% of biomedical research is wasted, summing up to $268 billion. Implementation science tries to bridge this no-do gap. This bridge tries to bridge the trial world with the real world. The active surveillance for PMI also suffers from the same problem. Even though it is now guideline recommended, other hospitals in Switzerland and worldwide are hesitant to take up this practice. A lot is still unknown before this screening can be widely implemented. So we started Implement PMI, a prospective multi-center pre-post comparison study to add to the knowledge base. As part of this, we prospectively asked ourselves the question, which implementation strategies do we need to make this active surveillance for PMI work in other settings? We planned to implement the intervention in different hospitals, namely the cantonal hospitals of Olten, Solothurn, and Lucerne, and university hospitals of Geneva and Innsbruck. We identified barriers which could hinder the implementation in those settings and mapped them to the updated CIPHER framework. We called them assumed barriers, since we anticipated those before implementation. Then we selected implementation strategy to help us overcome those barriers and reported them according to the ERIC taxonomies and the Proctor model. Here you can see a simplified graphic model of the CIPHER framework. It describes where barriers can take place, namely the outer setting, the inner setting, individuals, the implementation process, and the innovation in itself. I will now show you some examples of barriers that we found in our project. In the implementation process, we had the problem that we did not fully assess the setting prior to implementation. So our information on the context, where we wanted to implement this innovation, was limited. For the outer setting, We had to adapt to different cantonal and country-specific conditions and laws, and also manuals and algorithms for the diagnosis and management of PMI are not known or not widely available. In the inner setting, we anticipated, based on our experience in Basel, that the information flow and the communication between departments and disciplines may be difficult. And on an individual level, we thought that maybe we could lack persons to lead the efforts to implement the innovation, provide support, and also take responsibility. Now I will report to you one of the implementation strategies that we used to overcome some of our barriers. When we report implementation strategies, it is always important to name them, define them, and specify them. So we named our implementation strategies after the ERIC taxonomies. Then we defined them according to the widely accepted method paper of Powell et al. And then we specified them after the Proctor model. In our case, we specified that we would have a study coordinator and doctoral students. They would provide training to the implementation team, to the cardiologists, and to the anesthetists. Then we also said that they should do this training throughout the study, but also at least 2 times. As a justification, we already had some studies that this implementation strategy is effective when trying to implement guideline-recommended screenings or complex interventions. So I will conclude with some of my key messages. Gaining knowledge in the implementation of evidence-based practices could reduce research waste and save money. An implementation strategy should address barriers and be adapted to the context to facilitate the implementation. And also, when reporting implementation strategies, one should define and specify them precisely to inform further implementation. Thank you very much.
Okay, super presentation. It is open for questions. Implementation science is really important and not done well, and I really admire the approach you're taking. Very thoughtful.
Thank you.
I'm fascinated to know what your markers of success are going to be for the implementation of this particular program. I don't know if you have got that far yet in terms of defining exactly what they're going to be, but I'd be interested in your thoughts.
So, of course, we defined some implementation outcomes that we want to assess. We are not that far to give you some results right now, no. But we will, of course, look at the reach. So how many, when we are then in the post-implementation phase, how many patients got the screening in the end? Then also, if they had a PMI, how many of those patients then also had a cardiac consultation. Mm-hmm. We will look at the costs. Yeah, that's just some of our examples. Yeah.
Okay. One other thought. In my experience, implementing things that make the lives of the person who's got to do the implementation easier is much more successful than doing something that makes their life more difficult. Do you think that in your consultations that you've done so far, there is a group of clinicians that are ready to embrace this beyond the biomarker enthusiasts that we have in Basel? Because my experience speaking to anaesthetists and surgeons in this space is that they are more reluctant than we are in terms of embracing the concept. So have you identified barriers from specific patient groups?
So, yeah, of course, we had some instances where we had surgery disciplines that kind of opted out. Mm-hmm. And said they don't want their patients to receive screenings. Okay. And in this case, we were just going on without those disciplines. Okay. So when implementing, it is always important to try to adapt. In your innovation, you always have core components of the innovation that you cannot adapt. So for us, it is that those troponin measurements have to take place. But there are a lot of things around there that are adaptable, and it's important to adapt the innovation to the context to then facilitate the acceptance and adoption, of course. We also had a center that was not planned initially and wanted to start.
Okay,
Yeah.
good. Well, that's encouraging, but I think that's a great philosophy, adapt, and you'll learn a lot from this process. I'm absolutely sure of it. Very well done. Thank you.
Thank you.